This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Good to see everyone on our first Fellows Conference of the year. Today we have one of our esteemed second year fellows, Rachel Warnock, who will be talking about cardiac toxicology. Rachel did med school at Emory, residency at Emory, and then for the Triple Crown, we were lucky enough to recruit her here for Emory Fellowship. Rachel, take it away.
Thanks, Dr. Coley. So I'm Rachel. I'm going to be talking today about cardiac toxicology. I have a few cases in order to accomplish these objectives. I thought they were pretty interesting, and so I'm excited to share them. A few of them, a couple of them I've seen, some I've gotten from other colleagues, so I'm excited to share with you. My objectives today are to recognize the clinical manifestations of overdoses of cardiotoxic substances and understand the mechanism of toxicity for these substances and how this ultimately relates to their treatment. And it's important so we can understand the role of us cardiologists in the management of cardiac toxicity. So first case is a 49-year-old man. He had only had hypertension. So he was brought in after being arrested in order to get medical clearance so they could incarcerate him. The reason being is because he was reported by EMS to have had something in his mouth that he would not spit out for them. So they brought him to the hospital. On arrival, he got more and more sleepy, lethargic, and started having generalized tonic-clonic seizures. When he came in, his initial vital signs were just significant for hypertension and tachycardia. So while he's kind of getting a little more sleepy, one of the medical team opened up his mouth and removed the following image. This is not the real image, but removed the following from his airway. So you can see this bag of white substance. So there were a lot of bags and they had all ruptured, and there was presumed cocaine all throughout his oropharynx. So shortly after, he's still kind of lethargic. After his seizure, he develops this rhythm. You can see his wide complex. And then shortly after, he develops hypotension and ultimately loses a pulse. And so while they're setting up to start CPR, they start CPR. And because one of the attendings in the ER in this case was a toxicologist, he saw this rhythm, saw the clinical scenario, and decided to push an amp of sodium bicarb based on his suspicion. And so at the first pulse check, they get ROSC, and then they see this rhythm instead. So you can see the complex has narrowed. And those were just representative strips, but this is his actual 12-lead EKG, and you can see that he has sinus tachycardia, a prolonged QT interval, and then if you look at AVR, the terminal R wave component is a little abnormal, which is characteristic of this toxicity. So he continued to be hypotensive, and so he was started on vasopressors. So they go to try to intubate him. Again, he's sleepy, he just coded, but he's found to have this white powder all throughout his airway, and there's blood and the powder everywhere that I can't really see much. Also was found to have significant airway edema, and so he ultimately underwent successful cricothyroidotomy in the CPR bay. He gets admitted to the MICU. They ultimately convert him to a surgical airway tracheostomy. They finally confirmed that his UDS is positive for cocaine, confirmed the suspicions from earlier. And eventually he actually does really well. He had his tracheostomy decannulated during the same hospitalization and got discharged 4 weeks later and, walked out of the hospital, which was a, good result based on the circumstances. So this was obviously a case of cocaine toxicity. So cocaine is grown from the Erythroxylum coca plant, which grows mainly in South America, the West Indies, and Indonesia. The coca leaf was integral to the Incan culture dating back thousands and thousands of years, but cocaine was first isolated in the 1800s from the coca plant and was noted to have anesthetic properties, which were capitalized by the medical community to use in procedures. Eventually, actually several years later, we learned about the toxic properties and the side effects, and so its use was limited in the early 1900s. For recreational use of cocaine, the alkaloid form is converted into a salt that can be either inhaled, can be dissolved and injected, or it can be applied directly to mucous membranes. It can also be smoked as crack cocaine if you dissolve it in water at a base. In the body, it's metabolized to these three metabolites that cause the majority of the physiologic effects. And those effects are mainly by blocking the reuptake of synthetic amines, mainly dopamine, epinephrine, norepinephrine, and serotonin, causing severely increased sympathetic tone. And this has consequences on virtually every part of the cardiovascular system. As seen in this diagram, this is from a review in JACC. And the acute cardiac consequences include myocardial infarction, aortic dissection, and arrhythmias. The mechanism of myocardial infarction and ischemia are shown here. You have increased myocardial oxygen demand due to the severe catecholamine surge, and this is coupled with vasoconstriction. Cocaine upregulates endothelin 1, decreased nitric oxide, and increased alpha stimulation. And finally, you have an increase in prothrombotic factors on a background of accelerated atherosclerosis that happens with chronic use. And so it follows that chest pain is a very common chief complaint in cocaine users. We've probably all seen it. However, there's actually been 2 large-scale registry studies that show that only 6% of people who present with chest pain in the setting of cocaine use actually had acute MI. And so this approach was to cocaine use and acute chest pain was proposed by the 2012 AHA guidelines, and it's outlined in this review here. The management is fairly similar to non-cocaine users, but does advocate for a trial of nitrates or calcium channel blockers in patients with ST elevation, given the high tendency for vasospasm. Now, those with high risk features such as elevated troponin, hemodynamic instability, and recurrent chest pain should be admitted for monitoring and medical management, ultimately reserving invasive angiography, as you can see here by the guidelines, for those with ongoing chest pain and who are unresponsive to medical therapy. I wanted to make a quick note about beta blocker use. So there's this notion that using beta blockers in cocaine use can cause severe hypertension or worsening coronary artery vasoconstriction due to unopposed alpha stimulation. And as a result of a few smaller studies, the use of beta blockers in cocaine-associated chest pain was recommended against in the 2008 AHA consensus statement guidelines. However, as you can see here, this evidence was based on not really strong evidence. The majority of studies that have come since haven't really had the same results. So this meta-analysis in 2018 combined 5 trials and showed really no difference in MI or all-cause mortality between those who got beta blocker and those who didn't. And I wanted to highlight one of the studies that was included in the meta-analysis. This is a retrospective cohort study in 2010 that showed the same results. Patients were on multiple types of beta blockers, including atenolol, metoprolol, labetalol, propranolol, and carvedilol, and the results persisted even after the non-selective beta blockers, labetalol and carvedilol, were excluded, supporting the notion that maybe the more selective beta blockers are actually not as harmful as we originally thought. Nonetheless, the 2012 guidelines give non-selective beta blockers a 2B recommendation for use after vasodilators have already been given. And so my takeaway is that potentially non-selective beta blockers are the better choice in initial management in emergency management, but even selective beta blockers can be used in the longer term and should actually be used especially if there's another indication like heart failure or something like that. And there's a really good article there's the Hospital Medicine Things We Do for No Reason series. This is the visual abstract from it if you're interested in reading more about it. And so as seen in our patient case, the cocaine also has arrhythmogenic effects. It blocks sodium channels, thus it acts like a class 1C antiarrhythmic. And so like these, it's also pH and use dependent. So it's exacerbated at the higher heart rates that's seen with the sympathetic surge in cocaine use. It can also block the potassium channels as well, like we saw in our patient, causing QTc prolongation. At really high doses, it can present with wide complex arrhythmias, like other sodium channel blockers or TCA toxicity. And the classic EKG findings of cocaine this channel blockade include the terminal R wave changes in lead AVR, signifying a significant rightward shift, like we saw in our patient. And so these effects can be ameliorated by hypertonic sodium bicarb, like was given, can give sodium chloride. Sorry, here's an EKG, or even lidocaine. So lidocaine works by competitively binding sodium channels and ultimately displacing the cocaine. So it's beneficial even though it works in the same mechanism. It's not first line, but it can be used in refractory cases in which you've given a lot of sodium bicarb and the QRS is continuing to widen. Okay, so our next case is a 60-year-old female. She had a history of heart failure with a mild reduced EF of 40 to 45%. She had AFib, diabetes, and she was brought in from a nursing home for lethargy. She was ultimately transferred to Emory. Her initial vital signs showed a blood pressure of 82/41 and a heart rate of 30. And this was her EKG, as you can see, with a junctional bradycardia. A review of her medication showed the following. So she was on digoxin 0.25 daily. She was on Lasix 80. It had recently been increased from 40 milligrams by her outside provider. She was on losartan and Eliquis as well. Initial labs showed a hypokalemia of a potassium of 3.1, a normal creatinine of 1.0, and a digoxin level of 3.9, which is kind of double the upper limit of where toxic levels start to occur. She was initially given IV fluids and her blood pressure improved to the 90s/50s, but her heart rate still remained low. So she was then given Digifab, which improved her heart rate to the 50s and 60s. Her symptoms ultimately improved and she did really well. She was discharged home after spending 4 days in the hospital. Her home digoxin was discontinued. So this is digoxin toxicity. So the digoxin is a cardiac glycoside that comes from the digitalis plant, or otherwise known as foxglove, as you can see here. Its medicinal use was described by the British botanist William Withering, who used it in patients with dropsy, or as we know it, edema and congestive heart failure. You can see here by his publication on the right. The effects of digoxin are mediated by inhibition of the sodium-potassium ATPase pump. And so directly, this causes increased intracellular calcium, which is the main mechanism by which it causes increased inotropy. Additionally, it also leads to increased automaticity and decreased conduction velocity. Indirectly, it leads to increased parasympathetic tone, which is the main mechanism by which it achieves rate control in atrial fibrillation. This occurs by slowing conduction through the SA and AV nodes and increasing sensitivity of the baroreceptors, thus attenuating the effects of the sympathetic nervous system on increasing heart rate. The electrical effects of digoxin are demonstrated here. They cause an early brief prolongation followed by an overall shortening of the action potential. At higher concentrations of digoxin, the resting membrane potential becomes less negative, allowing for delayed after depolarization, seen here in this third panel. If they reach threshold, they can cause premature depolarizations and can lead to the tachycardia fibrillation of the myocytes that we can see. In the SA and AV node on the right, however, the effects are slightly different due to the dominating parasympathetic effects, and it ultimately causes decreased conduction velocity through the nodes and causes an increase in the refractory period. The atria are more sensitive to cholinergic effects than the ventricles are, which explains the overall effect on the conduction system and how digoxin can be used for rate control in atrial arrhythmias. Digoxin can basically cause any arrhythmia, but there are some that are more characteristic, such as atrial tachycardias with AV block, owing to the mechanisms I just mentioned. And as you can see that here with what's called regularized AFib. This bottom one with atrial tachycardia with block and frequent PVCs. Bidirectional VT is seen here. It's the kind of rare board question that can occur with dig toxicity, and it's represented by alternating QRS axis every other beat. And then finally, this last slide shows the digitalis effect on EKGs, this sagging ST segment, or otherwise known as like Salvador Dali's mustache, because it kind of looks like the same shape. And you can usually see it more evidently in the lateral leads. So there are several factors that can put a patient at risk for chronic digoxin toxicity. Dehydration and renal failure can both reduce digoxin clearance, and then hypokalemia can potentiate the effects on the sodium-potassium ATPase blockade, which should be contrasted with the hyperkalemia that occurs once you're already digoxin toxic, but low levels can predispose you to that toxicity. There are also some medications that increase the serum levels of digoxin, mainly through interacting with its cellular transport and metabolism. And the most commonly used and co-administered are amiodarone and the non-dihydropyridine calcium channel blockers. So the management of cardiac manifestations of digoxin toxicity is mostly supportive, but I wanted to talk first about digoxin-specific antibody fragments, or Digifab or Digibind. It's an antibody that binds free digoxin and helps establish a concentration gradient to free digoxin from the binding sites and improve elimination. The indications to use it are listed here. So first one is if you have a hemodynamically unstable rhythm, obviously you should use Digifab. Two, if you have hyperkalemia, which is defined as greater than 5, which is actually not that high, in addition to having other mechanisms of acute toxicity, such as renal failure or GI symptoms. If you have end organ damage, like the renal failure, like altered mental status. And then finally, it's a little controversial, but if some people advocate for in severe levels of ingestion to just empirically use Digifab, and that's defined as a level greater than 10, or an amount greater than 10 for adults, and then the level itself is greater than 10 for acute ingestions or 4 in chronic ingestion. So our patient kind of almost reached that threshold. So cardiac specific supportive care is listed here. Digifab should be readily available in our institution and should be given for patients with toxicity, but these interventions can also be used while waiting for it, or if it's not available. For bradyarrhythmias, atropine is the intervention of choice, followed by pacing. So previous teaching actually recommended against pacing, but it can be used to temporize. The real caution is just that patients sometimes required a lot higher than normal current to achieve capture. And some people advise against sympathomimetics just because to increase the risk of ventricular arrhythmias unless it's absolutely necessary, although they can be used. For ventricular arrhythmias, again, Digifab is first line. And also, the previous teaching was to recommend against defibrillation, but now, just like pacing, it just is taught that it just probably may not be as effective or require a lot higher voltage. There's also some case reports supporting the use of lidocaine and phenytoin for ventricular arrhythmias, although, like a lot of things in toxicology, it hasn't been backed up by large studies. Okay, so this third case is a 76-year-old female. She had history of stroke, hypertension, paroxysmal AFib, atrial flutter, and actually had a recent CTI ablation 3 months before, who was brought in for dizziness and lethargy. She was able to tell us that she'd reported taking extra doses of both her metoprolol and her amiodarone. Her initial vital signs showed a heart rate of 28 and a blood pressure of 83/44. She didn't have any clinical evidence of heart failure when she came in, but she did have lactic acid of 3.7 and a creatinine of 1. This is her initial EKG, kind of similar, actually pretty similar to our last patient. And this is her baseline. So she was given IV fluids. She was started on dopamine, and her blood pressure and heart rate improved. Her heart rate went up to the 40s, but she remained in that same rhythm. She was given IV glucagon, and her heart rate improved to the 50s, although she had some vomiting, which is a known side effect of IV glucagon. Over the next 12 hours, she was weaned off of dopamine, and her lactate ultimately normalized and was discharged in good condition and taken off of her metoprolol. So this is an example of beta blocker toxicity. So the first beta blocker was made in 1958. It was called pronetholol and sold under the brand name called Alderlin, which is named after Alderley Park, which is where the pharmaceutical company that it was invented at was located. The drug unfortunately was discontinued quickly because it caused thymic tumors in mice, but propranolol quickly came about a few years later. And interestingly, the brand name Inderol came from an anagram of the original name Alderlin, which I thought was interesting. So that's where the brand name for propranolol comes from. So this is a review from med school, but the action of beta blockers really depends on the beta receptors that they antagonize. And as a review, beta 1 receptors act mainly on the heart with effects on the kidney and eye as well. Beta 2 receptors act mainly on the bronchioles and the peripheral vasculature, and both beta 2 and 3 have endocrine effects, which the goal of which is to ultimately increase glucose availability for the tissues. And beta blockers cause the reverse of all of these. And in overdose, the main effects come through beta 1 antagonism, causing decreased chronotropy and inotropy. However, depending on the selectivity of the drug itself, they can also cause extra cardiac effects. The manifestations of beta blocker overdose usually occur within 6 hours of ingestion, unless it was sotalol or one of the sustained formulations. And it's usually more likely in older, sicker baseline patients, and younger patients typically can do quite well and just be asymptomatic, mainly because they don't rely as much on the sympathetic stimulation to maintain their cardiac output. And so overdose usually manifests as bradycardia, hypotension, and heart failure. The presenting rhythms typically are often early PR prolongation and early overdose, and can progress to sinus pauses and sinus arrest. An AV nodal conduction impairment can also occur and manifest as complete heart block. So the management of beta blocker overdose takes a stepwise approach. So for all patients with bradycardia and hypotension, initial management should start with IV fluids and atropine. The next line therapy that should be given to all patients with symptoms is glucagon. And as a reminder, glucagon acts through the same pathway as beta adrenergic stimulation, but uses a different receptor, thus bypassing the beta receptors altogether to ultimately increase cyclic uh, AMP and increase adenylate cyclase activity. It can also inhibit phosphodiesterase activity as well to increase cyclic AMP. Note though, like our patient, glucagon can cause nausea and vomiting, so it's important to watch out for those side effects with its administration, and that can ultimately be limiting in how much can be given. Another therapy that can and likely should be used is high-dose insulin and glucose therapy. The AHA guidelines for this topic actually give this therapy a higher level of recommendation than glucagon therapy. As you can see here, it's a class 1 indication where glucagon is 2A. And there is some data to suggest superior outcomes to vasopressors alone, and some signal that this could be vasopressor sparing. So the main mechanism as seen here is increased inotropy. At high doses, insulin has a direct inotropic effect by impairing the sodium calcium antiporter, thus leading to increased intracellular calcium. Additionally, the insulin causes an increase in the glucose supply within the myocytes, just kind of floods them with glucose, thus improving their function. And finally, can have a bit of a vasodilatory effect, causing improved afterload and contractility. And it mainly acts to improve the contractility and blood pressure, and notably doesn't really always help with bradycardia. The dosing for insulin here is usually starting with 0.5 to 1 units per kilogram per hour, which in comparison, this is 5 to 10 times the usual dosing that is used for DKA. So it's very, very high doses of insulin. So you have to be careful about keeping up with the glucose. It can make you very hypoglycemic, so you have to keep up with your glucose and other electrolytes. But it should be a very highly commonly used therapy. Other therapies that you could use are IV calcium salts, either calcium chloride or gluconate. These also probably work similarly by increasing inotropy, like insulin, mainly help with the hypotension that occurs rather than the heart rate itself. And so for vasopressor or alternative heart rate agents, epinephrine is seen as the agent of choice. The main thought here is to avoid isoproterenol because it's a pure beta agonist. And so what people have seen in the literature is that you often need really, really high doses in order to overcome the beta antagonism effect. And at these high doses, you can start to see some peripheral vasodilation, which can worsen hypotension. They don't do as well as if you just used epinephrine. Some more controversial therapies include pacing and traditional inotropes. Kind of like, as I mentioned with digoxin, you can use ventricular pacing but it actually often fails to capture, and just due to the metabolic effects of the overdose. Additionally, there are some reports of ventricular pacing actually decreasing blood pressure. It's been postulated that this is due to the disorganized atrial activity or ventricular relaxation, but it's not totally clear, and a lot of this comes from just case reports. And phosphodiesterase inhibitors such as milrinone are not typically recommended due to the vasodilation and hypotension that occurs. And similar to isoproterenol, dobutamine has also not historically been affected. So kind of the moral of the story is traditional therapies for bradycardia and hypotension may actually not be as effective in overdose just because of the profound metabolic insults that occur. And it's really important to consider the more directed medical therapies targeted at the underlying mechanisms. So the fourth case I have here is a 17-year-old female. She has a history of bipolar disorder, and she came in after an intentional overdose of amlodipine. She took 26 10-milligram tablets. She took them at like 11:15 a.m. and came in to around 12 p.m. And she was able to tell initial providers that she did not ingest anything else. It was an intentional overdose. It was actually she actually presented initially to an outside hospital, but ultimately got transferred to Emory. Initially, she was asymptomatic and tearful. Her only vital sign was tachycardia. She had a heart rate of 141 and systolic blood pressures between 90 and 100. So because of her known overdose, she was given fluids, glucagon, and calcium. 3 hours later, she rapidly developed multipressor shock. She was started on norepinephrine, epinephrine, and vasopressin. Her bedside echo by the providers at the other hospital showed a hyperdynamic biventricular function. Her EKG just showed sinus tachycardia, and she was given intralipid emulsion and activated charcoal. She was ultimately, because of how sick she was, transferred to EUH for consideration of MARS or ECMO and arrived around 6 p.m. She's admitted to the ICU where she had ongoing elevated pressure requirements. She got methylene blue, angiotensin 2, and hydroxycobalamin. Overnight, she was started on the high-dose insulin protocol, like I mentioned earlier, and MARS therapy. Later that afternoon, however, she developed worsening hypoxic respiratory failure from pulmonary edema. At least that was what was thought, and she required intubation. The next day, she continued to have declining respiratory status with evidence of ARDS, and so she was required initiation of VV ECMO. Eventually, she was weaned off pressors, decannulated from ECMO, and extubated 2 days later. So she actually ended up doing really well. As you can imagine, she was followed by psychiatry during her admission, and they deemed her safe for discharge home with her family, and she was discharged home a week later in good condition. So that was an evidence of severe calcium channel blocker overdose, and I wanted to use that case because it just it shows how sick these patients can get. So calcium channel blockers have been around since the 1960s, and they're the most common poison fatality amongst cardiovascular drugs. There's not a lot of exciting stuff in the history of the drug. I did find that there's a spider called the desert grass spider, or Aganelopsis aperta, that produces a toxin that blocks calcium channels. It's called agatoxin, and it mainly acts by preventing neurotransmitter release, and it causes a rapid, long-lasting paralysis in the prey of the spider. The good news is that the spider lives in more dry climates like the Southwest, and also the toxin, which is seen here on the right, is more insect selective, so it really only causes mild symptoms of pain and swelling if humans get bit. So it's kind of good news for us. There are many types of calcium receptors in the body, but the targets of medications we use are the L-type voltage-gated channels, and the difference between the classes of calcium channel blockers is which component of the alpha subunit of the same channel they bind to. And this changes their affinity for the channels in different tissues. At therapeutic doses that we use, the dihydropyridines like diltiazem and verapamil mainly act at the SA and AV node, while the non-dihydropyridines like diltiazem and verapamil mainly act at the SA and AV node, while the non-dihydropyridines act in the peripheral vasculature. At toxic doses, however, the receptor selectivity is often lost and can manifest with both primary cardiac and vasodilatory effects. And so the main manifestation of calcium channel overdose are hypotension and cardiogenic shock. In milder ingestions, the predominant mechanism is vasodilation, and you can thus see a reflex tachycardia, like was initially seen in our patient. However, with more severe ingestions, you can get bradycardia. You can also see ARDS due to vasodilation in the precapillary pulmonary beds, and you look like our patient had. And you can also see hyperglycemia because the insulin release from the pancreas also relies on the same L-type calcium channels. And so that's ultimately inhibited, leading to hyperglycemia. And the degree of hyperglycemia is considered prognostic in these overdoses. And the management of calcium channel blocker overdose is really similar to beta blocker overdose, so I won't spend as much time on it The initial management involves IV crystalloid or atropine if they're bradycardic, glucagon and IV calcium salts like we used before. But oftentimes in severe overdoses, like the patient we saw, they won't be sufficient to maintain their hemodynamics. And so you often need to throw a lot of different therapies at these patients. And the AHA again gives a class 1 recommendation for high dose insulin therapy as an early important intervention. You also need adjunct use of vasopressors is often also needed in these patients. And something important to note that I actually learned from the toxicology note that was written on this patient is that they often require a lot higher vasopressor doses than is typically used as institutional maximums, which can it makes people a little bit more nervous, but it's been shown that you can use these doses are typically okay to use. You don't usually get the classic ischemic side effects that can be seen with high dose vasopressors. And then finally, kind of like our patient, they may need advanced therapy such as MARS or ECMO. MARS is a newer therapy for overdose, and this patient from earlier actually is being written up for as part of a case series that's being written about the use of MARS therapy in patients with calcium channel blocker and beta blocker overdose. So stay tuned for that. So those are all the cases I have. The key takeaways that I wanted to highlight is one, just call the Poison Control Center. They're a really, really great resource. They're staffed 24/7 with the phones are staffed by a non-physician clinician who screens all the calls, and then if needed, they patch you through to somebody who's on call. It's usually a toxicology fellow plus an attending for support, kind of like being a cardiology fellow on call, and they're extremely knowledgeable. They as you probably could tell by this presentation, a lot of the literature for toxicology is a lot of it is case-based. And so they're just really knowledgeable about all the cases that have been used in the past and know that what's successful and what's not successful to use. So just a subtle plug for the toxicology department. They're really, really, they can be really helpful in these cases and are just super smart. And if you've ever seen their notes are incredible. They have it's kind of like an ID note. They have a lot of citations and just so much detail that can be really helpful if needed for these patients. And the other thing I kind of took away and wanted to impart is that traditional supportive care measures may not be effective in severe overdoses. So as cardiology, we're often called for the hemodynamics and the arrhythmias, and we can do things that are more typical for non-overdose cases like pacing and shocking, and you can use antiarrhythmics, but the reality is that they don't tend to be as effective, and it's actually more effective if you understand the mechanism or at least understand what should be used and what therapies can be used for patients that are a little bit more directed at the overdose, and that's typically more effective than just using kind of traditional supportive care mechanisms. So I thought that was interesting, and I didn't really realize that before I started looking into this. And so the majority of content that I got here are from this textbook called Goldfrank's Toxicologic Emergencies, which is available through the Emory library. I think it's kind of like the Bible for toxicology, and it's got a ton of information. A lot of it is more than we would need to know as cardiologists, but it's really valuable. So a lot of the stuff comes from either here or the AHA guidelines. Like I mentioned, there's a lot of the data that comes for toxicology is a lot of it's case-based. It's a little bit harder to do randomized control trials when the amount of people that are presenting with these overdoses are either there's not as many cases or they're often very complex, multiple ingestions and stuff like that. So a lot of stuff comes from case reports or this, which are collated into this textbook. So I'd like to thank Tori Earhart's one of the toxicology fellows who helped me with this presentation and helped provide cases. And then Tyler Warnock's my husband. He's one of the he was an ER resident here and had one of the cases as well and helped me with that. And these are some pictures of my dog, Wallace. So thanks. I'll take any questions.
Rachel, thank you very much. That was a great talk for this morning. Very interesting cases, and more so, I was very interested in the management of these cases and how things that we thought traditionally can work, they don't work. That was a great talk. One comment I had was while you were making and putting together this presentation, did you come across other common recreational substance abuse? Because you started with the cocaine case, and I know this is prevalent in usually inner cities, especially the Metro Atlanta area. But have you come across any other recreational toxic conditions that can affect the heart?
Yeah, I was thinking about so I didn't have any about methamphetamine abuse because I think that's we're seeing that a lot more.
That's right.
So I was thinking about including another case of that. I just didn't have one to use.
Yeah, yeah.
And I didn't know how much time I would have, but I think if I were to do this, and now I look like I have plenty of time, so I could have done that. But that was another one I considered using as well.
Exactly. I mean, the methamphetamines, it just depends on the geographical location where you are. I mean, can be very prevalent and has interesting effects on the heart, both short-term and long-term. That's something worth investigating and reading upon, especially if you are going to be practicing in a more so of a rural area. But very good talk. I will open up for questions. I think I saw Dr. De Casamaras had a comment in the chat. Let me
Yeah, is
open it
this
up.
he's asking about early gastric lavage and activated charcoal. The third case was beta blockers, and we did not actually use activated charcoal for that, but the calcium channel blocker case, which actually had timestamps. So I wonder if you were asking about that one. They did actually use they gave her activated charcoal. I don't know about gastric lavage, but at the other hospital she was at, she got activated. Yeah, calcium. She got activated charcoal. So there's I didn't mention these because I know we don't really see from the emergency setting, but the people advocate for I guess I don't know how I would call these therapies, but both activated charcoal and usually gastric lavage can be used. The gastric lavage is it's not necessarily controversial, but it has to be carefully used just because a lot of times the patients have altered mental status and have high risk for aspiration. So you have to be really careful when you do this. But um, the ER colleagues are better trained to see this, and we're not going to manage these, but usually people advocate for those therapies too.
Hey, Rachel, nice job. This is Shannon Walker. Just quickly on the subject of methamphetamines, I came from UCSF, and at our SF County General Hospital, half of our cardiology service were patients who had methamphetamine use disorder and either had severe PH or severe heart failure. I actually didn't see a lot of cocaine, so it's almost like the drugs have switched for me now. My question, either for you or some of the HF people, is I remember being taught to avoid DIG in patients with amyloid because it can bind to the amyloid fibrils, and then they're more sensitive to toxicities. I'm wondering if that can still be used, maybe in lower doses and just monitored carefully, or if it's just something that's typically just avoided in the setting of amyloid.
Yeah, Shannon, I feel embarrassed, answering this question when Dr. Faisal Merchant is on. I think he dropped off, but, you're absolutely right. I mean, the traditional teaching was, that digoxin will adhere more to the myofibrils that are affected by the amyloid deposition. But when I researched this myself a few years ago in response to a question from one of our fellows, I really didn't see a lot of strong evidence behind that, and it was only a kind of very weak evidence. Speaking to Kunal Bhatt, who does and sees most of our amyloid patients, he has not seen it as well. However, it's still kind of one recommendation that we still give. I have personally used digoxin on some patients who have amyloid or suspected to have amyloid. And however, I agree with you. I think low doses, extremely very meticulous monitoring is warranted, especially that these patients who have TTR amyloid are already older, have multiple comorbid conditions, especially renal dysfunction. So you won't go on to your traditional 250 microgram, probably 62.5, and really close monitoring and targeting a very low target level for digoxin. That will be my kind of guess, but and practice, but I don't think there's any scientific evidence behind it.
Got it. Okay, thanks.
Dr. Williams says, do they no longer recommend IV calcium for calcium channel blocker overdose?
Yeah, let me show you. Ooh. So it's still used for both calcium channel blocker and IV, and beta blocker are pretty similar. Here is the traditional like AHA guidelines. They don't actually they say it's a 2A, so it's reasonable to administer. I think it sounds great. It sounds like a great idea, just like give a bunch of calcium, but I think in practice it's like hasn't been super effective, but is fine and probably not harmful. But you do have to obviously you have to monitor calcium levels. I saw that some like threshold of I believe like 11 or 12 to stop using it once you get to that level, and but that's non-ionized, so you should use an ionized calcium level to titrate, but I think it's not as an effective therapy, to summarize.
So, moral of your stories, Rachel, call toxicology and improve cardiology notes.
Improve
Improve our notes. You're saying that our notes are bad.
Our notes aren't
But
bad.
I'm
There's
just kidding.
just better notes out there.
I know, that's right.
Okay.
You're absolutely right. Rachel, thank you very much for this fantastic talk. Good kickoff for the year. And we will see you all next time. Thank you very much.
The preceding program is copyrighted by Emory University.